She came in talking about shadows that followed her, voices that commented on her every move, and a terror she could not name. To the clinicians who first saw her, the picture looked like the opening chapter of a serious psychiatric illness. But something else was happening inside her brain, something that no psychiatric medication would touch. Anti-NMDA receptor encephalitis is a condition in which the body's own immune system produces antibodies that attack a specific protein in the brain. That protein, the NMDA receptor, short for N-methyl-D aspartate receptor, plays a central role in how neurons communicate, how memories form, and how behavior is regulated. When antibodies bind to it and disrupt its function, the effects can look, at first, almost indistinguishable from a psychiatric crisis. Understanding how that confusion happens and why it matters is what this episode is about. Consider the life context of a young adult in their 20s, a period when the first episodes of schizophrenia, bipolar disorder, and other primary psychiatric conditions most commonly emerge. This is also the demographic most frequently affected by anti-NMDA receptor encephalitis, according to the clinical literature. The overlap is not coincidental. It is, in fact, the core of the diagnostic problem. A person in this age group arrives at a clinic or emergency department with hallucinations, perceptions without an external source, alongside delusions, which are fixed false beliefs that resist correction, and profound behavioral disorganization. Family members describe a personality that has shifted over days or weeks. Sleep has collapsed. Anxiety is overwhelming. The person may be agitated, or they may be strangely still, locked in a catatonic state, a condition in which movement and responsiveness become severely reduced. These are real symptoms causing real suffering. And in the early phase of anti-NMDA receptor encephalitis, they may be the only symptoms present. There may be no fever, no obvious neurological signs, no reason yet to look beyond psychiatry. The clinical timeline documented in the peer-reviewed literature describes a condition that often begins with what resembles a viral illness, fatigue, mild fever, headache, before the psychiatric symptoms emerge. This prodrome, meaning the early warning phase before the main illness declares itself, can last days. Then come the behavioral changes. In the early weeks, a patient may be admitted to a psychiatric unit. Antipsychotic medications, drugs designed to reduce hallucinations and delusions in primary psychiatric disorders, are tried. The response is poor or absent. The condition does not follow the expected trajectory of a first psychiatric episode. Then, in many cases, the picture changes. Neurological features begin to emerge. Seizures, abnormal electrical discharges in the brain, may occur. Movement disorders appear. Involuntary, repetitive motions of the face, lips, or limbs, a feature clinicians call dyskinesia. Consciousness becomes impaired. The autonomic nervous system, the network that regulates heart rate, blood pressure, and breathing without conscious effort, may become unstable. In severe cases, patients require mechanical ventilation because the drive to breathe is compromised. This progression from psychiatric presentation to neurological deterioration is the documented pattern. But the peer-reviewed literature also notes that a small number of patients experience isolated psychiatric episodes without the full neurological cascade, making those cases particularly difficult to identify. The finding that redirects the clinical investigation is the detection of specific antibodies. In anti-NMDA receptor encephalitis, the immune system produces IgG antibodies, a class of immune protein directed against the GLU-N1 subunit of the NMDA receptor. These antibodies can be detected in cerebrospinal fluid, the liquid that surrounds the brain and spinal cord, obtained through a lumbar puncture, commonly called a spinal tap. They can also sometimes be detected in blood serum, though cerebrospinal fluid testing is considered more reliable for diagnosis. This antibody result is the pivot point. It transforms a clinical picture that resembled primary psychiatric illness into a recognized autoimmune syndrome with a defined mechanism and a treatment pathway. The diagnostic reasoning that leads to antibody testing is not straightforward, and the published consensus framework is explicit about why. Many conditions can produce overlapping symptoms. Infections of the brain, including viral encephalitis caused by herpes simplex virus, can cause psychiatric and neurological features. Toxic exposures, metabolic disturbances, and other autoimmune neurological diseases can mimic parts of the syndrome. Primary psychiatric disorders, schizophrenia, bipolar disorder with psychotic features, severe depression, remain far more common than anti-NMDA receptor encephalitis and must be genuinely considered, not dismissed. The consensus diagnostic approach organizes the evaluation around several elements: subacute onset, meaning symptoms that develop over days to weeks rather than years, a defined cluster of symptoms, reasonable exclusion of competing diagnoses, and targeted laboratory evidence. Antibody results may not be immediately available. Clinical judgment must operate in that gap. The proposed mechanism, as described in the clinical literature, involves antibody-mediated reduction in NMDA receptor activity at synapses, the junctions between neurons. Reduced NMDA receptor function disrupts the balance between excitatory and inhibitory signaling in the brain, which may explain both the psychiatric symptoms and the movement abnormalities. This is a hypothesis supported by laboratory and clinical evidence, though the full picture of how receptor disruption produces each symptom remains an area of ongoing investigation. Treatment, when the diagnosis is established, typically involves immunotherapy, interventions designed to reduce or remove the harmful antibodies and suppress the immune response driving their production. The literature documents that many patients improve with treatment, though the degree of recovery varies, and some patients experience relapses. What can and cannot be generalized from this disease pattern requires care. Anti-NMDA receptor encephalitis is a recognized condition, but it is not common. The peer-reviewed literature is explicit. Isolated psychiatric presentations without neurological features are uncommon within the already rare population of patients with this diagnosis. This means that the vast majority of people experiencing psychosis, hallucinations, or behavioral change are not experiencing autoimmune encephalitis. Primary psychiatric disorders are far more prevalent, and they deserve their own careful, evidence-based evaluation and treatment. What the recognition of anti-NMDA receptor encephalitis has contributed to medicine is a sharper awareness that the boundary between neurology and psychiatry is not always where it appears. When a psychiatric presentation is atypical, when it does not respond as expected, when neurological features emerge, when the trajectory is unusual, the clinical framework now includes a question that was not always asked. Could this be autoimmune? That question does not mean every psychiatric patient needs antibody testing. It means that clinicians have a more complete map of the territory, and that some patients who might previously have remained undiagnosed now have a path to an answer. Return for a moment to that opening image. A person in a clinical setting, frightened, experiencing something that feels like a fracture in reality, surrounded by people trying to understand what is happening. The symptoms were real. The suffering was real. And the investigation that followed, careful, methodical, willing to revise its assumptions, is what medicine looks like when it is working as it should. This video is based on a publicly documented medical case and is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.